Good morning, everyone. My name is Dr. Michael Bruno Jr., and I'm a faculty member in the Department of Health Sciences at Drexel University. This morning, I'll be presenting exercise recommendations for adults living with dementia, benefits of, and strategies for supporting a good life. This is one lecture in addition to my dear friend and colleague Dr. Stella Volpe's lecture, which is entitled Dietary Strategies and Considerations for Adults Living with Dementia, which is part of our symposium entitled Lifestyle Therapies to Support a Good Life for Adults Living with Dementia and Their Care Partners. To help get us started with this particular talk, what I really would like to do is start with a case study. Mrs. Smith cares for her husband, who is 80 years of age and has moderate symptoms of dementia and other chronic conditions that affect his mobility. Since his diagnosis 4 years prior, Mrs. Smith has been having difficulty managing her husband's increasing physical dependence as he is a fall risk, has difficulty getting in and out of the shower, chair, and bed. She is also managing a range of behavior changes. Mr. Smith, for example, paces, asks questions repeatedly, tries to leave home, follows Mrs. Smith throughout the home, misplaces items, and becomes agitated and rejects help. Medications are not effective, triggered side effects, and were discontinued. By chance, Mrs. Smith learned about the Alzheimer's Disease Association from a neighbor and has since received helpful information, but she is not interested in attending their support groups. Their children live in another city and are unable to assist Mrs. Smith on a daily basis, although they do occasionally provide her with some respite. As the Smiths do not receive in-home help, Mrs. Smith stopped working so she can provide full-time, hands-on care at home. Because of this, finances have been strained, and Mrs. Smith feels isolated and depressed, has back pain from the physical strain of helping Mr. Smith in and out of bed and on and off of chairs, and she is not sleeping well. She's missed several of her own doctor's appointments and sometimes forgets to take her own medications for her heart condition. Mrs. Smith is one of 16 million family members in the United States with the full-time responsibility of providing long-term care, and she is one of over 50 million families worldwide who live with dementia. I hope you get a sense for what we're going to be covering today. I've broken my talk down into a series of 8 objectives that I think we'll go through in turn. The first thing that I want to cover is what is considered normal and abnormal aging. What does research tell us about the acute effects and the long-term adaptations of exercise training for bodily and mental health? Then we'll get into some of the benefits that exercise has for some of the controllable risk factors that predispose people for Alzheimer's disease and related dementias, followed by differentiating what the difference between Alzheimer's disease and dementia really is. We'll then talk a little bit about what the mission of dementia-capable care is, how exercise can impact cognitive function, living with people who live with Alzheimer's disease and related dementias, and then get into some possible mechanisms for why we think exercise is effective. We'll then talk about some of the cost effectiveness of the programs and provide everyone with some general exercise testing and prescription recommendations to help support this very vulnerable and growing population live to their best ability to function. So to get us started, what is considered normal and abnormal aging? Well, when I was preparing for this talk, I realized that there's a lot of different definitions that exist. But really, I think what it comes down to is that healthy aging is all about creating an environment and an opportunity that will enable people to be and do what they have reason to value throughout their lives. You can see some of the other definitions, such as being free of disease, not being a requirement of healthy aging. The World Health Organization has defined it as a process of developing and maintaining functional ability. And finally, functional ability is all about having the capabilities that enable people to be and do what they have reason to value. What do we mean by functional ability, though? I think functional ability is all about having the capabilities that enable a person to be who they want to be and do what they want to do. But we need to realize that Functional ability is a very diverse and relative term, as there is no typical older individual. We also need to highlight some of the gross inequities that exist across the aging population, as 75% of the diversity in capacity and circumstance observed in older age is a function of the cumulative impact of advantages and disadvantages people have across their lives. So, what is abnormal aging then? I think that really begs the question. Abnormal aging can include a number of different things. One would be issues with eyesight, could be a sign of cataracts or glaucoma. Person may also experience issues with the sensation of touch, could be a sign of either a neurological issue or possibly a medication side effect. Person may exhibit some kind of behavior change. Okay, and what we're really looking for is uncharacteristic behavior changes, such as a severe mood swing that could be a sign of depression, or perhaps new onset Alzheimer's disease. And finally, memory loss or confusion, the sign that most people associate with Alzheimer's disease and related dementias. This is particularly important when something that a person understands or a person values is forgotten. When something that is significant in that person's lives that is forgotten, this is a major sign. So now that we have a good understanding of what the difference between normal and abnormal aging is, I think this then leads into a nice discussion for us to talk about what does research tell us about the acute benefits and the chronic adaptations of exercise for the improvement of bodily and mental health for the aging population, and then we'll get into the specifics about cognitive function. We clearly know that there are known benefits of body composition when someone performs aerobic and resistive exercise training. Engaging in any kind of physical activity will definitely have profound effects on decreasing a person's fat mass and improving their fat-free mass. We know that exercise is also beneficial in increasing the skeletal muscle size and strength, both of which are known to decline with aging. In a classic study by Maria Fiataroni Singh in 1994, she conducted a randomized controlled trial comparing progressive resistance exercise training in 100 frail nursing home residents over a 10-week period. And from the study, she found that skeletal muscle strength improved by 113%. Functional measures, including gait speed and stair climbing, were also found to improve in the exercise but not control group. So this therefore shows that performing physical activity and exercise has known benefits on skeletal muscle size, strength, and functional outcomes in the aging population. We also know that exercise has really good effects for muscle fiber typing, particularly because type 2 muscle fibers are often considered to decline with aging. And as this particular figure here shows, exercise training can slow or mitigate the speed at which fiber typing changes with aging. So more importantly, exercise training can slow or deter the progression and loss of type 2 muscle fiber typing. But of course, I think when we think about exercise for aging, we really go back to activities of daily living. All of these things are really important. But if we perform routine bouts of exercise, aerobic and resistive exercise, we know that there are going to be improvements in strength. We know that there's going to be improvements in vitality. And these are all going to translate into a person being able to be who they want to be and do what they want to do. With respect to some reflexes, motor units, and muscle physiology, we also know that exercise can preserve our reflex response and the timing, and it can help retain motor unit recruitment. Things, again, that if we do not use as we become more sedentary across the lifespan, that this can be a detriment to aging and lead to further functional decline. We know there's cardiovascular benefits, of course, with exercise. Exercise will obviously reduce our risk for all-cause morbidity and mortality. We see that there's a lessening in arterial stiffness. You can see this from this slide here, where exercise preserves vascular signaling. Okay, so essentially, the condition of endothelial dysfunction, which is shown here on the middle portion of this slide, okay, is that exercise can preserve the vascular signaling and promote normal vasomotion patterns, so vasoconstriction and vasodilation patterns. This is important because it helps us to ensure that we have an optimal AVO2 difference at the muscle site when we are exercising. Okay. And so if we have optimal, if we can maintain endothelial function, we can ensure that we're getting adequate amounts of oxygenated blood to these tissues to adequately nourish them and provide them with the oxygen they need to perform metabolic functions within our membranes. We know there's pulmonary benefits, such as exercise has the ability to maintain our ventilatory capacity and oxygen saturation. We're all very familiar with these curves shown on the slide. But what about depression? I think this is one that's, a really good concern for a lot of folks that are interested in this talk. We know that exercise can reduce depressive symptoms when it's performed in the context of a group setting, because the group setting will provide opportunities for the older adult to have opportunities for social engagement. But one of the things that I had done and I'd really been interested in is, well, that might work for the older population, but what about those who are elder and already have Alzheimer's disease or some kind of dementia? When I was going through the literature, one of the things that I really realized was that there's been few studies that have attempted to explore the benefits of exercise on depression in people who live with dementia. And in a study that was conducted by Bostrom et al. In 2016, they had found that there was no superior effect of a high-intensity functional exercise program where 40 exercise training sessions were completed over a 4-month period, and they found that the exercise therapies themselves had no superior effect on depression symptoms compared with a control activity. That does not mean that the exercise was not beneficial for other outcomes that we've described thus far in this presentation. However, for the outcome of depression, it was found to not be superior to a control or standard of care therapy. Importantly, the authors did highlight that the findings of this study should be replicated with 3-armed randomized control trials to control for the natural course of depression symptoms, and I could tell you that a 4-month intervention may be insufficient to determine the long-term benefits needed from exercise training for these outcomes in this population. So now that we know what exercise does for older individuals in general, what are some of the possible benefits of exercise on the controllable risk factors that predispose somebody to have a greater likelihood of acquiring Alzheimer's disease and related dementias? What can people do to control the risk factors to prevent getting Alzheimer's disease in the first place? And we know that exercise has very acute and chronic adaptations with respect to controlling systolic and diastolic blood pressure. We know that there is an acute reduction in systolic blood pressure at the magnitude of 5 to 7 millimeters of mercury systolic and 2 to 3 millimeters of mercury in diastolic. These findings have been substantiated by Dr. Linda Pescatello and her group, and one of the key findings of this is that we know that this change in systolic and diastolic blood pressure is often exercise intensity dependent. What this graph here is showing you is that on the x-axis, you have exercise intensity as a percentage of the VO2 max, and on the y-axis, you have the typical delta for systolic and diastolic blood pressure. And what you can typically see is that as people engage in more vigorous physical activities, they are typically going to yield more pronounced or significant blood pressure reduction. So treating hypertension can really be one of the most important things that people can do to prevent the likelihood of acquiring Alzheimer's disease and related dementias, and higher intensity activities seems to be better for that particular outcome. With respect to cholesterol management, we know that aerobic exercise can reduce the low-density lipoprotein cholesterol at the magnitude between 3 to 6 milligrams per deciliter. However, their effects on HDL cholesterol are really not fully understood at this particular time. Interestingly, resistance exercise has been shown to improve LDL cholesterol at a magnitude of 6 to 9 milligrams per deciliter. So while compared to more pharmacological interventions such as statin therapies, we can reduce cholesterol, but not to the same extent that these other medications can. So it's very, very important that for the outcome of cholesterol, that we integrate appropriate dietary interventions, which I know Dr. Volpe covered in her talk. So diet is very, very important, but exercise can improve modest improvements between 6 upwards of 9 milligrams per deciliter reduction in the LDL cholesterol. But we have to be realistic that most individuals who are trying to control their cholesterol with diet and exercise, it may be insufficient, and so we may need to also integrate statin therapies. We also know that diabetes is improved with the performance of aerobic and resistance exercise, right? We know that it improves glucose tolerance. We know that it improves insulin sensitivity, so on and so forth. So I think at this point in the talk, you may say to yourself, well, these are all things that I think was a good refresher. Definitely enhances my understanding of what I know about aging. But what's the real difference between Alzheimer's disease and dementia? And that's what we're going to get into next. So dementia, as you can see from this slide, I want you to think of it sort of how we think about cardiovascular disease, right? So if cardiovascular disease is an all-encompassing set of diseases that exist within it, dementia is the same thing for all kind of cognitive impairments that occur with aging. So dementia is going to operationally be defined as the loss of mental processing. But very importantly, the loss in mental processing needs to exist at such a severity that it interferes with the person's daily ability to function. Okay? So we see that there's decline in mental processing, but the decline in mental processing needs to be at a magnitude where it's now affecting the person's everyday life. Okay? Dementia, however, as itself is not a disease, but is rather a group of symptoms that may accompany certain kinds of diseases, right? That is very different from Alzheimer's disease, okay? Where Alzheimer's disease is a progressive neurodegenerative disease characterized by the loss of function and death of nerve cells, okay? So we have this loss of function of nerve cells, and we have the death of nerve cells. And this is going to occur in several areas of the brain. Sadly, there are no cures for Alzheimer's disease at this particular point in time, and it is the most common form of dementia. Okay? But we also have other kinds of dementia that are important to understand, such as vascular dementia or multi-infarct dementia. This kind of dementia often occurs concurrently with Alzheimer's disease, and it will typically be more common in men than it will be for women, particularly because men tend to be at a slightly higher stroke risk compared to women. The onset of vascular dementia is usually also going to be more sudden and abrupt than Alzheimer's disease, which is more progressive and slower. Okay. We also have Lewy bodies dementia, which follows more of a fluctuating course, right? So it's not sort of this linear course that we typically expect with vascular dementia or Alzheimer's disease. This is going to be more of a fluctuating course. And the key sign and symptom that's going to associate with Lewy bodies is you typically see the person suffering from multiple episodes of hallucinations. So they're seeing things there that aren't really there, and the hallucinations are a sign of when the person is fluctuating in and out of different states of their cognitive function. And then lastly, we have frontotemporal dementia, which often occurs earlier in life, early onset dementia. And typically, this is going to be including Pick's disease and is in primary positive aphasia. So one of the things you see with frontotemporal dementia is this directly affects the cerebral cortex and the frontal lobe of the brain, and we typically see changes in the person's personality and communication habits, and that will typically precede a long-term loss in memory. So although dementia is largely considered to be, I think, this group of symptoms that characterizes memory loss, there are different physiological mechanisms and pathogenesis factors that ultimately differentiate them one by one. So to really understand and get a handle on what we mean by function, typically as exercise scientists, we think about function as a physical function thing, right? But it's important to realize that there are really 4 different domains of function. So physical function, of course, is all about ambulation, skeletal muscle strength, endurance, balance, range of motion, things that we're able to objectively measure. But what about emotional health, right? Emotional health. We're really talking about the regulation, impulse control, depression, anxiety, post-traumatic stress disorders. How is the person's emotional function? We also need to consider sensory function, the person's ability to see, to hear, to feel, to taste, to smell, to experience pain. Okay, but What's largely categorized as the most important thing with our content of dementia is cognitive function, right? And cognitive function is a primary determinant of a person's ability to function in every activity. Well, cognitive function really is broken down into four different components: memory, attention, problem solving, and sequencing. We'll go through each of these in turn. So, when it comes to memory, right, if we're trying to capture memory as a cognitive function outcome, we really need to know that there's short-term and long-term memory, which I think most people probably have already been pretty familiar with. Short-term being holding information for a very short period of time. Longer-term memory can be held from days upwards for an entire lifetime. And the short-term memory, of course, is the first kind of memory to go in people that are living with dementia. Longer-term memory is the last to go. The other two kinds of memory that we also need to associate ourselves with is what we call procedural and working memory. So procedural memory is all about the long-term memory of performing a skill or a habit over and over and over again, like brushing your teeth. Working memory, on the other hand, is the short-term holding of information and our ability to manipulate and process new information. We process information that we determine to be important, and we can hold it there for a period of time with sustained attention. So what is attention? There's really four different ways we can think about attention: selected, divided, switching, and sustained attention. Well, if we go through each of these, selected attention means that we're processing one source of information at the expense of another. So we might be trying to process two different things at once, and you are sacrificing one thing for the betterment of the other thing. And then you completely sacrifice another piece to focus on something else. So think about if you've ever had a conversation with somebody and someone's on their phone, right? Somebody is sacrificing their attention to the person that they're having that conversation with at a table to be on their phone, right? They're not really listening to that person that's across from them. Their attention is solely on what they're doing on the phone. They're not listening at all to what the person is sitting across from them. We also have divided attention, right, which is a simultaneously processing two or more pieces of information at the same time. So this is someone, again, who may be able to handle two or three different things at the same time, but is flip-flopping, right, and is trying to process two different things at once, but they can't provide their full undivided attention to any one task. They're only half in on one task, half in on the other task. Okay. Someone who is switching is someone who's very good at multitasking. This is the alternatively processing one source of information followed by another source of information, right? So if you think about, maybe trying to do your laundry at the same time trying to clean your house, right? Well, you can do both of those things. You can switch tasks and go and put clothes from the washing machine into the dryer, and you can move the dirty clothes into the washing machine for the next load, and you can go and clean your house in between. So you can switch your attention between those different tasks very effectively. And then the last one is really what we think about, I think, as students, as academics, as someone who's reading, is sustained attention, which is maintaining a consistent focus on one source of information over a prolonged period of time. And I could tell you that this one is definitely one of the hardest ones to really do, especially in today's society where we're distracted by a lot of email messages and text messages, and we're constantly having so much demand for our attention. Sustained attention is really, really hard to do. And so there's a really good book by Cal Newport called Deep Work that I would really recommend people reading if you want some information and some strategies on how to make sure you have good sustained attention over time for your workflow. Let's talk a little bit about problem solving now. So problem solving is the ability to recognize a specific problem and formulate and implement those kinds of solutions. And so problem solving from a cognitive function perspective is really going to follow this cascade of events. The first thing we need to do is recognize that a problem has happened. Think about spilling the milk on the floor. You identify the source of why it fell on the ground and why the milk ended up on the floor. You devise a solution to resolve the problem, and then you implement it, right? And so you spill milk on the floor from the dinner table. Okay, you realize that milk is spilled on the floor. You identify the source. Okay, the gallon of milk was too close to the side of the table, and your fork, which is very close to the gallon of milk, created a greater likelihood you could knock your hand into the gallon of milk, and that knocked it onto the floor. You realize the milk's on the floor. What do I need to do to fix this? I need to go and get some cleaning solution. I need to go and get some paper towels or a towel, I need to clean the area up. And then you get up from the table, you go and get the equipment, and you implement the strategy to fix the problem. So the last, of course, then is what we call sequencing, right? And so sequencing is a person's ability to direct himself or herself through a series of steps of an activity. So if you think about somebody who is brushing their teeth, we have a person who may walk into the bathroom, then they open the cabinet, they get their toothbrush, put the toothpaste on the toothbrush, wet the toothbrush, brush their teeth, spit the toothpaste into the sink after they're finished, rinse their mouth, and put the toothbrush and the toothpaste back to their respective cabinets. It's important to realize, though, for people with dementia, every single one of us may have a slightly different sequence for how we brush our teeth. Some people leave their toothbrush in the bedroom. Some people leave their toothbrush in the bathroom. Some people use mouthwash first. Some people, put the toothpaste in a cabinet. Some people leave it on the countertop. And so it's really important that when we try to work with somebody who has dementia, that we do not just assume that they're going to follow and understand the same sequence that we use. So it's important to realize that when it comes to sequencing, we may have a different order of steps for each of these processes for something as a very simple task that we all communicate and we all do. And it's important that if you assume that the person with dementia is able to do the exact same thing as the way you've done it, you may create some confusion and the person may not necessarily know how to implement that activity. So really, it's our goal to really make sure that we are following a mission of dementia-capable care, so that way these individuals with Alzheimer's disease and related dementias can, effectively brush their teeth and truly live to their functional and their emotional potential. So what is dementia-capable care? Really, it's broken down into three different frameworks. We have a cognitive disabilities model, we have a theory of retrogenesis, and we have a person-centered care approach. The cognitive disabilities model was proposed by Dr. Claudia Allen. She's an occupational therapist who really focuses on how do we create an environment where we can give somebody living with dementia their best ability to function. We need to identify what is the task and what is the difficulty of the task so that this person can perform at their best ability to function. And she does this with what's called cognitive levels, and we'll go through those in just a few slides. But really what we're trying to do is this is not a disabilities model. This is really focusing on a capabilities model. What can the person with dementia do? We need to celebrate what they can do, not what they can't do. And we need to meet them with where they're at so that we can provide that person with their best ability to function at a just right approach task. The theory of retrogenesis was done by Dr. Barry Reisberg, and he hypothesized that people, as they progress through Alzheimer's disease and related dementias, will have a reverse in their development stages. So the more severe that a person's Alzheimer's disease and related dementia stage is, typically the more that they will revert back to the cognitive status of a child, right, or an infant or a toddler, things of that nature. And so we'll go through that. And then the last one is what's called Thomas Kitwood's person-centered care approach, which emphasizes sort of an interprofessional and interdisciplinary model of care where the person of dementia sort of is at the epicenter and is the focal point of all the care that they receive. So I think, with respect to Claudia Allen's model, the best ability to function model, really we need to understand what the person can do, what they will do, and what they may do. And so a person can do is realistic things that the person is able to do, such as walking with a walker. They may not be able to walk independently, but they can walk with a walker. So if you provide them with the mechanism of being able to use a walker, they can walk across the room. So what they can do. We also have to understand what they may do, which are possible activities that are externally motivated, right? And so it's really important that we have care partners in this role here. So, for instance, if you're working out in the garden and you want to plant some flowers, maybe that's an activity that the person with dementia really enjoyed, okay? And so you would want to invite that person to help you to participate in setting the flowers, for example. And then we have to think about what the person will do, which is a relevant activity that is typically going to be influenced by the person's interests and their motivations. So things that they will predictably do time and time again. So what are the Allen cognitive levels, right? Well, there are essentially 6 different Allen cognitive levels, And the further that you go into sort of this target, the more severe the dementia exists. So you can see here that at level 1, cognitive level, this is considered end stage dementia. And these are pretty much where the person is reverted back to an infant status, and all they can really do is have automatic actions. But importantly, I think it's important to highlight that the person can feel love. They know what it's like to be part of a community. Okay, so it's very important to be inclusive of this vulnerable population. Even though they may not be able to perform the exercises that we ask them to perform, we can work with them passively through a range of activities, and they know what it's like to feel love, what it's like to feel companionship, so on and so forth. So just because a person's in end stage dementia does not mean that there's nothing we can do for them. I think that's a very important message of this talk. We then have late stage dementia, where we have some procedural actions that can be performed. Okay, we have level 3, middle stage dementia, where manual actions can be performed. So think about somebody who can brush their teeth. You, as the care provider, would need to provide the environment. You would need to pull out the toothpaste and put it on the counter, have the toothbrush on the counter, so it's all right there. The person can recognize what they're supposed to do with those kinds of activities. Okay, someone who's at a level 2, where they're just doing postural actions, they may be seated eating lunch, and you can demonstrate to them what it's like to take a sip of their drink, for example. They see the cup, you can help assist putting their hand around the cup, and you can mimic what it's like to drink the fluid from the cup. And so that person can see that action and can replicate it. Okay, so they can do postural actions and overcome gravity. When you get to level 4 and 5, you're starting to get into a little bit more, a lesser stage of cognitive impairment, but this is where you can have goal-directed activities. Okay, so a goal-directed activities is typically somebody that's going to be youth-aged, right? So maybe somebody that can help you set the table for dinner, but maybe should not be left alone to cook on a hot stove independently, right? So while you're in the room, the person can do a lot of functional tasks, but they are going to need some level of supervision, right? But they can perform some of these tasks. Okay, they know what it means to grab the plates, they know where to get them from, and they can help you with those kinds of tasks. So really low risk kind of activities, I think, are appropriate for this level of cognitive function. And then level 5 is pretty much somebody that's within high school, upwards of an early, maybe most of the students that are attending this particular conference would be somewhere between 21, 22 years of age, where you have independent levels of activity. The person can drive a car, they can do tasks, they can be left alone, they can babysit people. And so this is a person who has, on the fringe, sort of like pre-dementia, is what's called mild cognitive impairment, okay? And that's considered level 5 of the ACL category. So again, the further you go to level 1, the more significant the cognitive impairment is. So there are a number of different assessment tools that we can use to obviously say, okay, well, now that I have a good appreciation of what dementia is and how it differentiates from Alzheimer's disease, like, how do I know if a person is at one of these levels? And there's a number of tools that I've shown here on the slide here, but I want to walk you through two of the more pronounced ones that are really, really important. And so one of the ones that a lot of the literature states is what's called the mini mental state exam, okay? And this is typically done in an interview status, and you're trying to assess the person's degree to which they are oriented with the year, the season, the date, the day, the month, so on and so forth. You're trying to assess their ability for attention and calculation, their ability to recall, and their language abilities, okay? This was largely considered one of the gold standards in cognitive function assessment before the MoCA came out. And so the MoCA is called the Montreal Cognitive Assessment Scale. This is a Philippine-based version when I was trying to find the images here. But really what you're trying to get the person to understand is you ask them to perform a series of tasks, and you're assessing their cognitive status out of 30 possible points. So 5 of the points is based off of their ability to perform this line tracing test, where if 1 goes to A and A goes to 2, 2 goes to B, B goes to 3, so on and so forth. And if they can successfully complete the line tracing test, they get a point for that. If they can replicate this cube here, they get a point for that. If they can, show 10 past 11, they have to draw the clock, they have to draw the hands on the clock, and then they have to be able to draw all the ticks on the clock. And so if they can get all those pieces correct, they get all 5 points. They then are asked to name each of these 3 animals. We ask them to recall some of these different names. So there's no points associated with this because 5 minutes later, we ask them to recall it down at this level. And really, the MoCA is very sensitive in being able to detect people at different stages of the Allen cognitive level status. And the general category is that anybody with a MoCA 26 or above is considered to have normal cognitive function. Anybody between 22 and 26 on a 30-point scale is considered to be in the mild cognitive impairment range. And anybody with a MoCA score that's less than 22 is considered to be in some form of dementia, with lower scores indicating more severe dementia symptoms. So before we actually get into what exercise does for cognitive function, I think it's also important to realize that with this population, there's a number of behavioral problems that often arise. And the behavioral problems are not because the person is just changing their behavior. It could be that, but oftentimes it's because it's an underlying problem for something else that's going on, such as pain, fear, a person's inability to express an unmet need. They feel scared because they have a loss of sense of their self, or they have inappropriate expectations of their caregiver. And so it's important to realize that if we notice behavior changes when we're working with this population, it's not because the person's trying to be difficult or that their behavior is changing. It's often because they're experiencing something else is going on under the hood that we really need to try and identify what that thing is. So maybe they forgot to take pain medications and they're experiencing pain. Maybe their loved one or their care provider is not with them and they're scared to be alone. So we need to be able to identify those kinds of things so that way we can implement successful exercise interventions. So with that, let's go ahead and talk a little bit about how exercise can impact cognitive function in individuals with Alzheimer's disease and related dementias. And one of the things that I really want to focus on in this talk, we will talk about aerobic exercise, but really it's resistance exercise that's recommended for most older adults because the primary focus is to improve physical function. And so here's a study that was conducted in 2012 by Vital et al. On the effects of weight training on cognitive function in elderly individuals with Alzheimer's disease. And as you can see here from the primary outcome of the paper, is that the authors found that there was no difference in cognitive function between resistance exercise training programs and social interaction groups. So this is sort of similar to what we found way back with the depression symptoms. And so in this particular study, Vital analyzed the effects of weight training or a usual care social gathering opportunity in 34 individuals who had Alzheimer's disease. The exercise group was performed 3 days per week. They did 3 sets of 20 repetitions, and they did 5 exercises that involved the major muscle groups of the body. Some of the challenges of this paper, however, was that they included a very small sample size. They used non-parametric statistical procedures, which may have limited their findings, perhaps by violating some of the basic assumptions of the procedures involved. And the authors ultimately concluded from these findings that programs with higher intensities would be needed with larger sample sizes. So to fill that gap, Fiataroni Singh, who conducted that study way back in 1994, where the 113% improvement in skeletal muscle size and strength was found in elderly individuals, and then later by Mavros et al. In 2016, really wanted to determine whether improvements in aerobic capacity and strength were possible after performing progressive resistance training. And they really wanted to know whether this mediated improvements in cognitive function. So they used a randomized double-blind control trial. They recruited 100 community-dwelling older adults that had mild cognitive impairment, so early stage or pre-dementia symptoms. And the intervention included progressive resistance training 2 to 3 days per week, and they did this for a period of 18 weeks, or roughly 24 weeks, or which is roughly 6 months in duration. And some of the outcome measures that they were really trying to elucidate with the cognitive function is they used the Alzheimer's disease assessment scale, they used the global executive and memory domains, they looked at peak strength, and they looked at VO2 peak. And on the next slide, what you're going to see here is a general mediation model. And what the authors found was that executive function and the person's self-regulation skills are really all about mental processes that enable us to plan, focus our attention, remember, and juggle multiple tasks. And so in this particular case, what you can see here in the upper left quadrant is that on a bivariate level, progressive resistance training correlated with the Alzheimer's disease cognitive function subscale, which is great to see. Resistance training correlated with the subscales. But importantly, the authors also considered a mediation outcome, where we're not only concerned on what progressive resistance training can do for the Alzheimer's disease cognitive subscale. But what is the effect of the progressive resistance training program on lower body muscular strength, and how do those changes in lower body muscular strength then affect the cognitive function? Very, very, very important in this particular point in time. And so, what the authors ultimately found with these mediated outcomes is that anabolic exercise, progressive resistance training, has clinically relevant benefits for cognition, skeletal muscular strength, and aerobic capacity. So there's a wide spectrum of benefits of performing PRT in people who have ADRDs. And importantly for this paper, which was not shown in previous studies, is that the strength gains that have been seen mediated the cognitive benefits. So it was not this bivariate relationship. It was really this path analysis where the resistance training improved lower body muscular strength, and the improvements in lower body muscular strength augmented changes in cognitive function. Very, very important finding. So then, of course, the big thing is, well, that's great that it worked, but why did it work? So what are some possible mechanisms that mediate the improvements in cognitive function? So in the same project by Fiataroni Singh, Broadhouse et al. Investigated the long-term neurostructural and cognitive impact changes of the PRT intervention in the 100 adults with mild cognitive impairment. And really what the authors found in this project was that the resistance exercise preserved and protected Alzheimer's vulnerable hippocampal regions of the brain, highlighted here in the red regions here on the slide. Okay. And what it was ultimately found was that these preservements of these brain regions were capable of being preserved for up to 1 year after the training. So remember, this study, they did 6 months of progressive resistance training, okay? And that 6 months of progressive resistance training preserved the hippocampal brain volumes of areas that are often vulnerable for Alzheimer's disease and related dementias, okay? And it was able to preserve these brain regions for up to 1 year following training. So very, very clinically relevant improvement in these outcomes. One of the other things that was also shown from this particular project was that resistance exercise led to long-term improvements in connectivity, okay, between the left hippocampus and the posterior cingulate, which was the part of the region that we referred to in the previous slide. And so in this particular side, you have an individual's functional connectome, and essentially what you're looking at is the correlation between all 116 brain regions in the left side of the brain and a heat map, essentially, right? And what we typically see is that there's a raw change in the functional connectivity between the left hippocampus and the prefrontal cortex over the 18-month intervention. And this box and whisker plot here is showing changes in the functional connectivity between the left prefrontal cortex and the hippocampus for each training group. So you see each of the different groups. And the findings here are essentially showing that the progressive resistance training was able to improve brain neuroplasticity and preserve hippocampal brain volume. So we're preserving the areas that Alzheimer's disease typically manifests itself within, and we're improving neuroplasticity, or the connections at which we learn things and the connections at which the brain can fire these neuronal signals. And so that's a really good thing in counteracting some of the deleterious effects of Alzheimer's disease, for example, which is a progressive neurodegenerative brain dysfunctional disease. And so these kind of findings, importantly, have also been confirmed in smaller studies prior to this larger study of 100 people with MCI. And these were done with proof of concept studies in smaller interventions. So it was really a really critical finding to see that these findings occurred. Some of the other mechanisms that also have been shown to associate with the benefits of exercise for cognitive function is there's a number of biochemical markers that exercise can improve. And without going through all the details of all of them from Jensen's paper, this was really a systematic review and meta-analysis of 8 studies, so a small number of studies, but it did include up to 447 patients in this cohort. And what really was important, I think, is that while we see that there are beneficial improvements in things such as testosterone and DHEA and declines in cortisol and BDNF and IGF-1, you see all the positive benefits with the biomarkers. And in some cases, we see that there are improvements with executive function, trail making tests, cognition, and picture recall. But unfortunately, for some of these projects, we see that activities of daily living really don't improve. They're sort of just maintained, which I think is an important thing to say, that that's really a win, because even if the exercise isn't causing an improvement in activities of daily living, it is at least maintaining the person's activity of daily living and is preventing it from regressing even more so along the course that it normally would. And so, an important finding that I think that came from this particular project was that the authors called for future studies with large sample sizes, more thorough exercise supervision. This is very important for all of the professionals and the clinical exercise professionals that are listening to this talk. Educated trainers and well-defined intensity measures, as well as various sampling protocols are needed. And so this is really advocating for the profession of exercise physiologists and clinical exercise physiologists who have the scientific background to work with these vulnerable populations. Because I can tell you that the occupational therapists, the physical therapists, there is not enough of them in most regions of at least the United States to be able to meet the increasing need that we're expecting to see increase up to 50-fold by the time 2050 comes around. So a very, very good sign for the progressive growth of ACSM certified professionals to work with this vulnerable population that unfortunately is expected to grow. So I think one of the things then is, what about aerobic exercise, right? And so I could have gone through a lot of different studies that talk about aerobic exercise, but really I think a study by my good friend Greg Panza and Linda Pescatello's group, really conducting a systematic review and meta-analysis of all exercise trials, really was trying to elucidate whether or not can aerobic exercise improve cognitive symptoms in people with Alzheimer's disease. And I've highlighted the major findings on the PowerPoint for you here. And really what you see is that aerobic exercise was found to be superior to other types of exercise, but more studies were ultimately determined to be needed to include more objective measures of dementia. And so what you're generally seeing here in the meta-analysis in this forest plot is, here you have the mean line, which is sort of the null finding. And here you have this red dotted line, which is the average effect size of what the exercise trials do for cognitive function. So anything that's moving to the right is really favoring exercise. And you can see that the average overall mean effect size across all of these different exercise studies was pretty modest to strong. I mean, this is considered a moderate effect, but it's trending toward a significant effect, 0.5 and above. And so this is really important, and I've powered a lot of my own clinical trials with this particular effect size. And so what does the exercise prescription actually look like from all of these different trials? Well, I think it's important to realize why we need the prescription in the first place, and it's because there are no universally recommended exercise prescriptions for individuals who live with Alzheimer's disease and related dementias. They're generally recommended to just follow the World Health Organization's 150 minutes per week of MVPA. And so what Pescatello's group sort of found was that really the frequency is probably somewhere between 3 to 4 days per week, moderate intensity, 130 minutes per week, or roughly 30 to 45 minutes per session, and it should be aerobic exercise. At least these are the aerobic recommendations. I have some recommendations that I'll provide with regards to the resistance exercise. But before I do, I think it's really important for us to understand what is the cost of providing this kind of care. And I think that's important because if you're working in a clinical setting, or if you're working in a setting, care providers and families are going to want to know, how much does this program cost? And if you're trying to sell the program as part of your existing program as a cardiac rehabilitation therapist in a fitness center, you need to be able to provide that this is going to be cost effective. And so in order to do so, one of the studies that was conducted out of Canada by Davis et al. In PLOS One Medicine was that really she was interested in understanding the economic evaluation of aerobic and resistance training programs compared to traditional balance training programs in older individuals with mild cognitive impairment. And what the authors ultimately found here was that the incremental cost, okay, which is essentially the total cost that a healthcare system will accrue for every additional unit that is being produced. So how much does it cost the program to get a meaningful outcome in a meaningful outcome from each participant? So if I invest a certain amount of money into this particular exercise program, what is the yield? What is the translation of the clinically relevant outcomes that I'm going to be able to expect to see from that program? And I need to know that it's cost effective and that it's going to see improvements. Okay, and the way it's typically calculated is by analyzing all the additional expenses that are involved in the production processes, such as materials, equipment you need, staffing, so forth. And you want to know how much a meaningful outcome is going to change with that investment. And with this particular protocol, in this group of older individuals with mild cognitive impairment, the authors were able to find that the Stroop test, which is one assessment of many of how we assess cognitive function, it's been used with both children as well as adults. And the findings essentially learned that for every dollar that a person puts into one of these particular programs, it's typically less costly and it typically yields higher Stroop scores, so it's more effective. So although the particulars of this particular paper did not include quantitative information in terms of dollars, what this particular analysis showed was that compared to a balance and a toning program, the resistance training was found to be the least costly and the most effective for improving cognitive function with Stroop tests. So that's important, I think, as we continue to move forward. But additional studies that provide those quantitative numbers of how much money can be saved, how much cognitive function can be improved is important. So now as we sort of conclude the talk, I think it's really important to understand how can care partners really help those living with dementia perform exercise, okay? And I think it's important to realize that they can help with safety, right? Care partners have a very important role because they are the primary person who's going to be responsible for assuring that the exercise is safe and effective. They can themselves administer something that is known as the EASY tool. And as you can see here, the EASY is a 6-item questionnaire that's used to screen for health issues and concerns for an older individual that's preparing to engage in exercise. And it's really used to develop what's called a tailored physical activity program that is appropriate for a wide variety of health circumstances and situations. And it will generally provide a recommendation and a resource for when the person who's living with dementia may experience a contraindication to exercise performance and who needs to have more formal pre-participation health screening. But generally speaking, pre-participation health screening, just simply going through a person's risk factors and using the traditional ACSM algorithm is sufficient. And for older adults, exercise testing is generally not recommended because oftentimes people who have risk factors will have their risk factors controlled and they're already ambulating at a moderate intensity activity. So really what the new algorithm, most people that are listening to this talk, I'm sure are familiar with it, really asks 3 questions. Do you exercise? Do you have signs or symptoms? And are you symptomatic? And the general recommendation for all people is to exercise safely if it's not vigorous activity, because vigorous activity poses the highest risk. And so if a person wants to engage in moderate activity, which is what we're recommending here, it's generally not recommended to have that. But for people who do want to go to vigorous intensity activities or have other more chronic, more serious health conditions, medical clearance is recommended. Some of the specific exercise tests that we can recommend for folks are typically functional in nature rather than a traditional VO2 max test or submax test. And there are things that we can perform pretty routinely in good ecological validity settings. So we can do something such as the short physical performance battery, right? We can use a 6-minute walk test. These are all things that people can perform within the comforts of their home or maybe at a local track, right? If they can time a 6-minute walk test. You do gait speed tests. These can be done in hallways. So they're really adaptable for a wide variety of settings and they are cost effective. But what about exercise prescriptions, right? So what, as a take-home point, can we really do and recommend people with exercise prescriptions? What can we provide at this point in time? What might an exercise prescription look like for this population? Knowing, of course, that no one universal prescription exists at this time. And so what we can see here is these are the ACSM FitVP exercise recommendations for older individuals. And if you look here, I have sort of summarized the meta-analysis data from Linda Pescatello's group, as well as some of the resistance training data that I've reviewed in this presentation. And really what the exercise prescription looks like is somewhere between 2 to 3 days per week seems to be feasible. Light to moderate activity seems to be feasible and approachable. And If it's aerobic, we really want to try and keep it between that 30 to 45-minute range, somewhere in that 130-minute per week volume recommendation. For resistance training, we want to keep it between 8 and 10 exercises, 1 to 3 sets, and 8 to 12 sets per reps per set. And I think these are achievable, right? And so if we prescribe 3 days per week, but we clean up at 2 days per week, I think then we're helping these individuals meet the recommendations to at least maintain their health. But to conclude, what are some real special considerations that we do need to think about that are applicable for people with dementia? And one, of course, is applicable to all older adults, and that is exercise-induced hyperthermia, right? So we know that there's a higher risk of death from hyperthermia because there's a thicker shell due to more adipose tissue that we develop over the lifespan. And so there's going to generally be a higher core temperature compared to younger individuals. And so we have to be careful about exercising in the heat. Not so much of a concern today as we're getting ready to enter the fall and the winter, and most of us are inside anyways. But it is something to consider for prescribing exercise in outdoor settings. We also need to think a little bit about medications, specifically some of the side effects of Alzheimer's disease medications that exist. And some of these medications often elicit issues with appetite, nausea, vomiting, diarrhea, muscle cramps, headaches, dizziness, fatigue, and insomnia. These are all sort of side effects of common medications such as acetylcholine esterase inhibitors or antioxidant type therapies or NDMA receptor blockers, so on and so forth. And so it's important to understand that if a person with dementia is prescribed dementia kind of medications, we really need to make sure that we understand the side effects of these meds, along with any medications that they may be taking for the risk factors for cardiovascular disease, and how these medications really interact pharmacologically or pharmacodynamically to impact a person's exercise performance. And so with that, I'll leave you. I'd like to thank everybody for giving me the opportunity to present this exercise talk. I'm so thankful for my colleague, Dr. Stella Volpe, for agreeing to participate in the session with me in the lifestyle therapy session. And I really like to just thank the Mid-Atlantic ACSM's Program Planning Committee and Executive Board for making this conference possible. I think, a lot of folks were really thinking that as we've been going through a pandemic, that it's really easy just to cancel the conference and try it again next year. The National ACSM, unfortunately, had to do that this year, and they went to an online program, and I think that sort of provided the lead for this program. So I'm so honored that we were able to have some version of a conference. If people are interested in connecting with me, here's my social media platform, here's my email address, and if there's any further questions that people have, please do not hesitate to contact me. And just to conclude, I've gone through a lot this fall with the pandemic, losing family members and so forth. So I just think it's really important to remember that when times are good, be grateful. When times are sad and challenging, be graceful, because tough times don't last, tough people do. Thank you all so very much for this opportunity, and I look forward to seeing you next week.